Hello, Dr. Valencia. My name is Justin. I'm the clinical pharmacist on floor 3. I am calling about Mr. Carl Williams. He is a mutual patient of ours, and I have been consulted to assist in Mr. Williams' discharge. He is to be converted from IV to PO medications. I'm talking about Mr. Williams himself. He is admitted 3 days ago and presented with fevers, chills, and a large pimple that he described to be painful and draining pus for the past few days on his right forearm. The site was cultured and found to show Staphylococcus aureus with a cutaneous abscess. Upon admission, the patients and heirs were also tested, and they tested positive for methicillin-resistant Staphylococcus aureus. Appropriately, an incision and drainage was performed, and he was put on vancomycin 1,250 milligrams every 12 hours for the past 3 days, which based off of today's trough levels, indicate a true trough of 10.5 micrograms per ml. Additionally, he is also given warfarin for his AFib, and some of the other medications include acetaminophen, hydrochlorothiazide, lisinopril, and metoprolol succinate. His past medical history reveals that he has an AFib event 10 years ago and has been diagnosed with hypertension for the past 20 years and gastroesophageal reflux disease for the past 30 years. He did have a recent C. diff infection that occurred less than 6 months ago, and that was the most recent antibiotic use that we have on record. As far as his social history goes, the patient has been adherent to his medications, and he goes to the gym 5 days a week and is a retired athlete who lives with his wife. His vitals indicate that his current blood pressure is at 114/82, which as per ACCA/AHA guidelines indicate that he is controlled, and he has a heart rate of 76, a respiratory rate of 14, and a temperature of 99.1 degrees Fahrenheit. Per the patient's wife, the patient did have a sulfa allergy to penicillin as a child, but that was reported to her from his mother, but they don't know the extent of the reaction itself. Now, since being on vancomycin inpatient, the patient has shown great clinical improvement and has been afebrile. Upon reviewing the CNS report, linozolid is being recommended as an alternative methicillin-resistant Staphylococcus aureus treatment for the current, in lieu of the current vancomycin antibiotic. This medication was selected due to the patient needing a PO medication while outpatient, and due to his current and concurrent warfarin usage, as well as his most recent C. diff infection, and his labs indicating a downtrend of hemoglobin and an uptrend in serum creatinine. Linozolid is not renally eliminated, has small interaction with warfarin, and has slight aplastic anemia. The goal is to resolve the infection with the least amount of side effects and to prevent a recurrence of the infection itself. Now, per the ISDA guidelines, linozolid dosing should be 600 milligrams every 12 hours for 10 days. Since there is a possibility that linozolid can interact with warfarin, we're also recommending that he go to an iron on a lab in 3 days and visit his primary care physician with labs to check for anemia in 10 days.